Okay, good morning and good afternoon to everyone on the call today. Welcome to our webinar, Quality Improvement Techniques to Improve Blood Pressure Screenings. My name is Rebecca Bally. I'm a Facilitation and Improvement Specialist with the Oregon Healthcare Quality Corporation, which has been contracted by HealthInsight and Acumenture Health in Oregon to coordinate and facilitate these LAN webinars. So my role today will be to moderate. And we have a lot to get through today, so I'm starting right on time with the promise that we will end right on time. First, a brief introduction to HealthInsight. HealthInsight is the Quality Innovation Network Quality Improvement Organization, ClinQIO, serving Nevada, New Mexico, Utah, and Oregon through Acumenture Health. There are 14 ClinQIOs that bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. ClinQIO work is grounded in principles that align with the goals of the Centers for Medicare and Medicaid Services, CMS, their quality strategy to eliminate disparities, strengthen infrastructure and data systems, enable innovation, and foster learning organizations. Along with 13 other regional ClinQIOs, HealthInsight is the leading healthcare quality improvement initiative, including the Million Hearts Initiative for the Medicare program for a 5-year period from 2014 to 2019, as guided by CMS. This webinar is part of the Learning and Action Network, or LAN, efforts under the CMS Project on Cardiac Health. Throughout the presentation today, we will be checking in with you, and we'd love to hear your feedback and your questions. So a quick review of the technology. To reduce feedback noise, everyone is and will remain on a global mute throughout the presentation. However, if you would like to ask your question verbally, you can raise your hand, which is a little icon next to your name in the attendee box to the right-hand side of your screen, and we can unmute you. We do have time set aside at the very end of the presentation to address your questions, and we appreciate everyone who submitted questions ahead of time during registration. So you can raise your hand to speak verbally your question, or you can feel free to type your questions in the question pane that is indicated in this image on the screen here. Also, if you have any technical issues throughout the presentation or concerns, feel free to message me or my colleague Marissa Sweeney, and we will do our best to troubleshoot any issues. We also ask you to please complete a post-webinar survey to help us on our improvement journey. Today we have some fantastic presenters. With us on the call is Rebecca Durham, a project manager at HealthInsight Utah. She works primarily in the physician office and home health settings. She is currently working on initiatives directed by CMS to improve cardiac care and increase immunization screening and vaccination rates in those settings. In addition, Rebecca facilitates and supports action groups from around the country that are made up of Healthcare Innovation Awardees, HCIAs. She graduated from the University of Utah with a Bachelor of Science in Communications and an emphasis in health and medicine. She also recently earned recognition as a Certified Professional of Healthcare Quality, CPHQ. Also on the call today in New Mexico is Susan Yeltsin, the Project Manager for Cardiac Programs, as well as the lead for all 4 states on this Million Hearts Initiative. Susan has a Bachelor of Science in Biology from Muskingum College and an MA in Psychology from Argosy University. She has been working at HealthInsight New Mexico for the past 7 years and is currently a project manager serving as the multi-state and New Mexico lead for the CMS Cardiovascular and Diabetes Improvement Project, and as the New Mexico lead for the CMS Behavioral Health Improvement Project. We will also hear today from Amber Buchert, Chronic Disease Program Coordinator at Nevada Health Centers, and from Jenny Wilson, Business Intelligence Manager from Nevada Health Centers, about a successful patient-centered blood pressure measurement improvement project. And with that, I will turn things over to Rebecca Durham.
Thank you. I'm going to turn on my webcam too so that I won't just be a voice in the sky. Hi to everybody, and thanks for joining us today on this call. As you can see, the learning objectives by the end of this call, we hope that you'll be able to recall at least one quality improvement method to use in your work setting, and we're going to go over some of those different methods today. Articulate blood pressure measurement guidelines, explore ways to improve current blood pressure measurement process to improve the Million Hearts blood pressure control measures, and create an action plan to improve and monitor change in blood pressure measurement. As Rebecca said, we've got a big agenda today, and so we're going to go through some of these things, show you some tools, introduce you to a few things that are at your disposal, and get you on your way. So I'm going to be in charge of advancing my slides here. Let's see if I can do it. Doesn't seem, oh, there we go. Just a little delay. So we'll be reviewing the guidelines, as I said. As with any good quality improvement project, we need to know where we're starting and where we're going. We've got a blood pressure assessment tool and EHR guide that you'll be introduced to. We'll hear a success story from Nevada Health Centers on what they're doing with some home blood pressure monitoring work, and introduction to some common quality improvement tools to help you on your way. And an action plan at the end, wrapped up with some Q&A if we have some time. So here are some blood pressure categories. We're not going to spend a lot of time on this. You can find this information at the American Heart Association website. You can see the, here we've got some different categories. Like I said, it's good to be familiar with what is categorized as prehypertension, what is the category, the systolic and the diastolic pressure, different stages as you're looking at your patient. And next, we've got a slide here about measuring blood pressure the right way. This list comes directly from the Adult Hypertension Clinical Practice Guidelines packet that was developed by the New York City Health and Hospital Corporation. This can be found and others on the Million Hearts website, so we encourage you to check out that website for more. But these are some guidelines for the patient, for the provider, for both, about the accurate way to measure blood pressure as you're starting on a quality improvement journey. Like I said, best practices, need to know what is important, and the tool that we're about to talk about will also help with this. So here in Utah, we work with a local Utah Million Hearts Coalition that's made up of all the people you can see here in this logo, and University of Utah, the local chapter of the American Heart Association, our couple, our local health department. And really the idea of developing this assessment was so that it could be used as an improvement tool. It really incorporates best practices from 3 categories. You already saw the slide about the accuracy of blood pressure readings. We've got a category about that, about office policies and procedures, documentation alerts and EHR. And the idea behind it is that this is a way for you to assess your clinic and find areas where you may want to improve, where you have gaps, and create an action plan. So I'm sort of giving you the PDF version. Is it stuck in transition? Give it a second. There we go. This blood pressure assessment can be found on the website that is www.healthinsight.org/blood-pressure, and it can be taken either online or in a PDF version. What you're looking at here is the PDF version. You can see the 3 different categories that I talked about. If you take this online and answer no to sorry, I just got a little pop-up saying that my connection is slow, so I apologize. Because I may have to stop sharing my webcam. So we'll see how this goes for a second. If you answer no to any of these questions during the online version of this assessment, then you will be directed to some resources that can immediately help you with that particular section of the assessment. Go ahead and turn this off. Goodbye. Okay, maybe this will go a little faster now. I've advanced to the next slide, but it doesn't want to cooperate. There we go.
Rebecca, we can see your advancements, I think, maybe before you can.
Oh, okay. It's delayed.
Oh, it's working.
All right. This is sort of a zoom in to one of those sections on the assessment relating to documentation alerts in EHR. As the slide indicated about the guidelines for diagnosis and guidelines for pre-hypertension, when you're creating a quality improvement organization or a quality improvement project, data definitely drives improvement. It drives what you do. It gives you a place to start. It gives you a goal to shoot for. And as you can see from this assessment question, let's say, for example, you say that you don't frequently use your EHR to query patients with a diagnosis of hypertension. That may be something that you want to pick to work on going forward. And this assessment will link you to some resources for that. We also have another resource that can help you with that. It's an EHR guide that was developed with our local health department and some funding from the CDC. This will really help you get into some cardiac-specific reports in your EHR, screenshots and tutorials for commonly used EHRs. Again, really meant to be used as in conjunction with your quality improvement project and guide you through that. Some screenshots, troubleshooting common problems. There's a section on quality measure selections, criteria for how to look for these patients who either are pre-hypertensive or have a diagnosis of hypertension so that you can come up with a project to intervene, and an outline of how to run a plan, do, study, act cycle with these folks. And we'll get into that a little bit more, what a PDSA cycle is later in the presentation. And that is just a quick overview of what tools you can find on the healthinsight.org/blood pressure website. There are also similar tools out if you go to the Million Hearts website. But I want to make sure we leave enough time for this success story from Nevada Health Centers to let you know what they've been up to and hear the great success that they've had. So I'm going to go ahead and turn the time over now to Jenny and Amber, if you want to pick it up from here.
Hello, everyone. My name is Amber Buchert, and I'm a certified clinical medical assistant and a community health worker. And I am the chronic disease program coordinator at Nevada Health Centers. Today I'll be speaking about our self-monitoring blood pressure program at Nevada Health Centers, care, addressing hypertension, empowering patients through patient-centered clinical care. I'll be sharing a little bit of background to the self-monitoring blood pressure program these three health centers participated in: Sierra Nevada Health Center, Virginia City Community Health Center, and Carson City School-Based Health Center. Dr. Shaheen developed a protocol for selecting the patients based on the following criteria. The patients we selected from were adults over 18 and had a diagnosis of hypertension or have had at least 2 visits with elevated blood pressure. After identifying 349 potential patients, we started calling them to tell them about the program and start scheduling them to come into the office to receive a free blood pressure monitor and training. Here are some of the measures that we are collecting through implementing this program: the number of patients participating, number of patients with improved pressures, the number of patients whose pressures remained the same, the number of patients who reported worsening pressures, the number of patients who followed their medication regimen, and the number of patient appointments needed when control is gained. So for the implementation of this program, I call patients to let them know about the program and how it could benefit them. They learn they will receive a blood pressure monitor and training in the health center, and that when the program ends or the provider releases them because they are in control, The blood pressure monitor is theirs to keep. They are also told their measurements will go into a database for collecting data, as well as into their electronic health record, and that their provider has access to those numbers in their chart each week as they report them. During a meeting with me, the patients learn some specific skills in obtaining their own blood pressure measurement. Patients learn the optimal position to sit and take a reading, how and where to place the cuff, as well as learning a few other things that can affect blood pressure, such as not resting before taking a measurement or placing a cuff over clothing. All of these things that can affect a reading are things we discuss. During the meeting, we also go over our blood pressure forms, and the patients do a practice blood pressure reading so they can practice writing down their measurements once in the office before going home to do it. They are also given a variety of ways to return their blood pressure logs to me weekly. Our patients learn specific skills to their new monitor, such as setting the date and time. They are given hands-on training in the office with their new blood pressure monitor and can ask any questions they have about it before leaving the health center. During the meeting, patients are given materials, and we discuss systolic and diastolic pressures and the charts showing blood pressure numbers by category according to the American Heart Association. We also discuss risk factors for hypertension, those that can be controlled and those that we have no control over, as well as natural ways to control blood pressure, like having a healthy diet, a low-sodium diet, keeping weight down, being physically active, limiting alcohol, not smoking, and stress management. The following are things that we do when a patient reports their weekly measurements. We enter the date, time, systolic measurement, diastolic measurement, and for each patient into a database for data collection. We enter the range of dates, the systolic range, the diastolic range, and heart rate range for each patient into the patient's electronic health record so that their provider has access to it. Providers may release patients from this program once the patient has shown consistent blood pressure measurements for a 30-day period that are in control. So for our June updates, we have 99 patients enrolled, the enrollment period of January 27th through June 3rd, 2016. And we have a 64% compliance rate, patients who submit their blood pressure readings on a regular basis. And we have 8 patients who have reached control and have been released from the program, although they are encouraged to continue daily monitoring. So we will be happy to take your questions when it's the right time to do so. Thank you.
Thank you so much, Amber. And I would like to encourage people to enter your questions into the question and answer pane on the right side of your screen. And we don't have any questions at this point, but if you think of a question later about this specific project, maybe just write that this question is for Amber or Jenny, and we can indicate that at the end of the presentation. And I think now we'll turn it over to Susan Yeltsin to talk about some QI tools.
Thank you. What I'm going to go over today are a few basic quality improvement tools that are simple and easy to use, but these can be very valuable in making real positive changes in your practice. So just to give you a brief overview, I'm going to go over the 5 whys tool, Fishbone diagrams, and the IHI model for improvement and PDSA cycles. And as you'll see, these 3 tools can each be used alone or in combination with each other. So when you want to improve a process or an outcome, it's much more effective and efficient to look at what the underlying processes are that are leading to the current situation than it would be to randomly pick things to change, hoping that this will lead to improvement. The first thing you want to do is find the main factor contributing to the current undesirable situation, and this is done through root cause analysis. So what root cause analysis is a structured team process that assists in identifying factors or causes of a system failure or underperformance. And I'm going to emphasize again the word team in that description, because this really should be a team process and should include as many staff members as possible that are either involved in or affected by the particular process you're trying to improve. It's important that when possible you not do this in isolation, because although you know your role and your involvement and you know what your barriers are, there may be other factors that you're not even aware of that are barriers in other parts of the system to other team members. So you want to start by creating a process improvement team that suits the needs of the organization and the issue. The first very simple tool which can be used to perform a root cause analysis is this 5 whys tool. This is a technique which is used to explore cause and effect relationships which underlie a particular problem. And the goal is to determine the root cause by repeating the question, why is that? Each answer will lead to the next question. And just some interesting history tidbits behind this tool. This technique was originally developed by Sakichi Toyota and was used in the Toyota Motor Corporation during evolution of its manufacturing process. And they still use this as a critical component of problem-solving training. Since then it's spread and now is used within quality improvement methodologies including Kaizen, Lean, and Six Sigma. So just a little history behind this tool. So I have an example of how this tool would be used. You would start out with a problem statement. So in this case, uncontrolled hypertension is not addressed during patient visits. The first question, why is that? Well, providers often overlook the high blood pressure readings. Why is that? Well, they focus on the specific symptoms leading to the visit. Well, why is their focus so narrow? Well, this particular organization is not using an EHR. There's not enough time during visits to go through and review all the patient information when they just want to review what's relevant to the presenting cause. Why does it take that much time? Because there's no way to quickly identify which patients have controlled hypertension, so they need to search through the charts for that info. Why can't you quickly identify which patients have uncontrolled hypertension? There's no system in place to flag these patients. So that is the root cause. There's no system in place to flag patients with uncontrolled hypertension at their visits. If you're wondering why this is 5 whys and not 6 or 7 whys, it's just because it has been found that in most cases, typically asking why 5 times is enough to get at an underlying cause. But if after 5 questions you still haven't arrived at a root cause, don't stop. Keep going. You can add a 6th or 7th level. You'll know when you hit the root cause because the last answer will suggest a broken process or a behavior which can be changed. So here in this example, you end up with a need to flag patients with uncontrolled hypertension. And you can come up with a way to do so. In this case, in the absence of an EHR, it was the medical assistant will place a red flag on the file when the blood pressure reading is higher than 140/90. Now, changing that one behavior might not always lead to your desired improvement. One thing to keep in mind is not all problems have a single root cause. If you want to uncover multiple root causes, you would repeat the 5 whys methodology, asking a different set of questions each time. A few additional rules to keep in mind when performing the 5 whys is distinguish of the analysis with the use of the expression and therefore. So for example, with the last 2 whys in this example, there is no system in place to flag the patients with uncontrolled hypertension. And therefore, there is no way to quickly identify these patients. Look for the cause step by step. Don't jump to conclusions. And try to make your answers as precise as possible. Assess the process, not people, and never leave human error as the root cause. You want to look for what inside the situation, what processes, what environmental factors led to the human error. Ask the question why until you get to the root cause. Another tool which can be used for root cause analysis and can be used in conjunction with the 5 whys is the Fishbone, or otherwise known as Ishikawa diagram. Now this diagram is a visual way to look at cause and effect. It's somewhat more structured than the 5 whys tool. The problem or effect is displayed at the head of the fish, and possible contributing causes are listed on the smaller bones under various cause categories. So a fishbone diagram can be helpful in looking at each of the categories to identify possible causes for a problem that might not otherwise be considered, because you're being directed to look at the categories and think of everything under that category that may impact the problem. Again, you should include team members who have personal knowledge of the processes and systems involved in the problem or event that you're investigating. So the steps in using the fishbone diagram are to, first of all, agree on the problem statement or the effect in the cause and effect, which is written at the mouth of the fish. Be as clear and specific as you can about the problem. Agree on the major categories that could contribute a cause to the problem, and these will be your main branches off the central arrow. These often include categories such as equipment or supply factors, environmental factors, rules, policy, and procedures, and people or staff factors. Have the group brainstorm all the possible causes of the problem. Ask, why does this happen? As each idea is given, the facilitator will write the causal factor as a branch from the appropriate category on the diagram. And causes can be written in several places if they relate to several categories. You'll ask again, why does this happen about each cause until you get to a root cause. So as you can see, we're bringing the 5 whys into use here to address each of the issues that comes up. So here is an example of a fishbone diagram in action. The problem statement in this case is inconsistent blood pressure readings are noted in patient charts. The categories it was decided might hold contributing factors are equipment and supplies, environmental, rules, policies, and procedures, and staff and people. Now, as you find potential causes under each category, remember, they may be symptoms and you want to keep asking the whys until you get at the root cause of each issue. So, for example, on this diagram under staff and people, we have medical assistants are inconsistent in use of best practices in taking blood pressure. Well, why is that? The organization does not promote consistent practices. Why is that? They don't have a formal protocol in place for taking a blood pressure. Ah, there's your cause, and that can be changed. So that's a solution to try. You can see where some paths might lead to the same cause, because if you look under rules, policies, and procedures, that was one that in the brainstorming came up right away. No formal protocols in place for taking the blood pressure. So not only is that under the rules and policies categories, but it also leads to inconsistent practices in the people, as seen in the staff and people category. So that would be one that you would probably want to address because it's popping up in multiple places. You'll often come up with multiple causes when using a fishbone, and in this case, you want to systematically go through and make changes to these one at a time. It's generally not good to say, oh, these 5 things in these different areas are contributing, so we're just going to hit these all at once, because that's really never the easiest way to do things in real life. It's usually best to start with one area with one small controlled change and to see whether that has an impact in a positive direction. So how do you go about implementing the changes you come up with one change at a time and seeing whether these are making improvements? Well, that can be done through using the IHI Model for Improvement and PDSA cycle. Now, IHI stands for the Institute of Healthcare Improvement, and they promote an improvement model that consists of 2 parts, 3 fundamental questions, which are, what are we trying to accomplish? How will we know that a change is an improvement? Because, of course, not all changes are improvements. And what change can we make that will result in an improvement? Then, once you've identified the answers to those questions, you can use the Plan, Do, Study, Act, or PDSA cycle to test these changes in real work setting. The PDSA cycle is what guides your test of a change to see if it really results in an improvement. So the steps in creating a change action using the PDSA cycle are, first of all, again, you want to start by forming the team. This should include anyone involved in or affected by the process. Then you want to plan. You need to set your aim. This should be time-specific and measurable, and should also define the specific parameters. So what population of patients do you want to try this with? What area do you want to try this with? Is this only going to be at first with 1 or 2 providers? Then you want to establish your measures. And quantitative measures are very important because you need to determine if a the specific change actually leads to an improvement, and the only way to know that is to be able to measure it and collect data. Now, there can be process measures as well as outcome measures. So, for example, if your outcome is going to be the number of times a patient with uncontrolled hypertension has that addressed by the provider during a session, a process measure associated might be, how much extra time is this taking in each appointment? So that you can have different sets of data through which you can look at any improvements and see whether improvements were made and whether they were reasonable given the amount of effort or added burden to the system. Because if not, you might want to try a different approach. Now, selecting changes. Ideally, these would come from a root cause analysis. So you've gone through your root cause to find your root cause and identified a key issue, and you would want to make a change to something that you know is a cause in the system. The do is the change of the test. You would go ahead and implement that in the area and parameters selected. Study refers to checking those measures, collecting the data, and seeing whether there is an improvement. And then when you're done, that leads to action. So in an action, it can either be implementing a change, either more fully in that area to a larger population, to a larger part of the organization, spreading change throughout the entire facility or to partnering facilities, and or realizing that the change didn't lead to the improvement you were hoping for, or that the process measures you collected showed that even though there was some improvement, it's not sustainable. And so in that case, your action is try a different change and start the cycle over again. Come up with a plan based upon your new change. Now, the PDSA tests a change in the real work setting and is meant to be a small, rapid cycle. So it should be done with one small group within your organization over a limited period of time. And this is because you really don't want to invest time and effort into getting your whole organization to change over to a new process before you have evidence that that change will lead to the improvement that you're looking for. A major plus of testing change and showing effectiveness on a small scale using the PDSA cycle before rolling it out to a broader scope is that if you've demonstrated its effectiveness, that's going to create momentum and generate buy-in. We know there's always resistance to change within systems, but if you have the results of a successful PDSA cycle to back it up, we don't know if this is really going to even work, is not going to be a legitimate cause for resistance. Often you will have to test a change several times and learn from each test, refining your changes through several PDSA cycles before the change is ready for implementation on a broader scale. Now, when you get to implementation, this is a permanent change to the way work is done. So we're done with the test, and we're now creating a permanent change in the system. This involves building the change into the organization as a new best practice. It can affect documentation, written policies, hiring, training, and aspects of organizational infrastructure that may have not been involved in the first PDA test. So because of this, when you implement, you may need to bring that PDSA cycle back again to address the spread of this throughout the organization. So that was a very brief and quick overview, but these are some pretty simple and useful tools, and I'd like you to think for a moment about how you will take these tools and apply them to create your own action plan. Think about what you are trying to accomplish. Who would need to be involved? What will your measures be? And remember, they need to be concrete and defined so you can collect data. As part of thinking about your measures, you want to make a prediction. These are measures that will hopefully be impacted. So what do you predict will happen to them as you implement your change? What will you change? Again, you will likely need to do a root cause analysis to get at this. When will you remeasure? How long will this PDSA cycle be? And how will you know if you've succeeded? Did the outcome match your prediction? What threshold in the measures, what level of improvement will mean that the change is worth implementing on a larger scale? So if you want to chat in a few thoughts on what your action plan will address, we would love to see some of these. And here's a slide which you can use as a template to create your own action plan based on a PDSA cycle. Again, the very first thing you want to do is come up with an aim. What do you want to impact? Create your plan, setting your aims, establishing your measures. These can be process as well as outcome measures. Do your root cause analysis so you know what element you want to change. Make a prediction about which direction those measures will move in. Set a period of time to try that change, and at the end of that time, collect those outcome and process improvement measures and determine if that change was successful enough to spread, or if you're going to start over with another change or modify that change and run through that quick cycle again before you spread it throughout the facility. Now, if you're hesitant to jump right into this, to implement these in your work settings, these are great tools to practice at home. And I have seen some wonderful examples of the use of root cause analysis and PDSA cycles in things like getting kids to school on time, exercising more consistently, and I'm using it right now to try to keep up better with my housework. So I actually love these tools, and I think they can really be fun, which is not a word we hear often in quality improvement. So that is all I have. Thank you very much, and if you have any questions regarding these tools, you can certainly ask them on the call, or if you have questions afterwards, any of your team leads at HealthInsight use these tools consistently and can answer any questions you may have that come up. Thank you.
Thank you so much, Susan. And we actually have time to allow people to sit through and think through a PDSA cycle or a plan that they might want to implement or something that they're working on in their organization. And so maybe I'll keep it on this slide for folks to be thinking and maybe write it down on a piece of paper or in a Word document. And just be thinking about this and chat it in if you're feeling brave or comfortable, and we can go ahead and answer some questions while you're doing that. So we had a couple of questions actually for Amber about your home blood pressure monitoring program. And A few of them were logistics questions, such as how did you work this project into your workflow, and who financially supported the project?
Hi, so this is Jenny Wilson, and I can speak to those 2 items. So financial support, we received a grant from Nevada Wellness, the state of Nevada, the Department of Public and Behavioral Health, and they were able to purchase 250 blood pressure cuffs through one portion of the grant, and then also, and then Amber was able to implement this into the workflow at really it's just one clinic with 2 satellite clinics. So we started very small with the data, or we started very small with the project, and we worked very closely with the physicians and providers at that clinic, and we did data mining for the patients so that it didn't really impact initially the workflow process. We kind of got to that point where we worked into actual workflow in the clinic. Does that answer the question?
Thank you, Jenny. I think it does answer the question, that particular one. There are a couple other questions, and this could maybe, Jenny, you could take a first stab at this, and then maybe Susan and Rebecca, you could talk about what you're hearing in some other clinics or other settings. The question is, if a patient's blood pressure is elevated in the office setting, but the patient states that their home blood pressures are normal, how is this reflected in their records or in their treatment plans?
So what the community health worker, what Amber does, is she'll take a range of the home blood pressure meetings, and she actually sends a message to the provider when those are reported. So when it's up to the provider to act on it, and we've had 8 patients actually dismissed from, or not dismissed, but released from returning their weekly blood pressure readings, because they are in control. So really it's a tool through the EHR for the provider to react to that scenario.
Great, thank you. I think that's very helpful. Rebecca or Susan, are you hearing similar things?
This is Rebecca. I would just say that type of scenario really sort of begs almost for a PDSA cycle around some sort of protocol or process, if there's none in place currently, to work with your providers and see how they want to handle that situation and put something in place for when that scenario comes up. So that in itself would be a great thing to test the change and see if it eliminates some of that discrepancy.
This is Susan. I agree. If in those guidelines for taking a blood pressure correctly that Rebecca presented, you may want to go through and look and see whether any of those could be contributing as a root cause to the higher blood pressure that's captured in the office.
Those are great points, and I actually leads to another question somebody was asking about, or I think it relates to another point that somebody was making about sort of this culture of continual improvement and how nothing is ever perfect, no process is ever totally finished, and there's always ways to be changing or adapting, and each situation might be different. Each patient or client might have a different situation. And so do any of you have any tips for how to foster sort of a culture of improvement in your setting?
So actually at Nevada Health Centers, they've gone through several PDSA cycles with this pilot. from where we're documenting in the EHR and how we're routing that to the providers and how the providers are reacting to that. So we're actually getting ready to expand the program to other clinics as well, and using what we've learned in this very short time of the pilot and rolling that out to the other clinics.
One very important thing is that there does have to be leadership buy-in, because for root cause analysis and quality improvement efforts to be successful organizationally, there has to be a culture of being willing to learn from mistakes or current processes that may not be best practices without blaming. So it really does need to start at the top.
And this is Rebecca. I would echo that and also say oftentimes when we're in clinics helping people do this quality improvement work, or in any really healthcare setting, it's absolutely crucial to identify a champion. It doesn't have to be a provider. Sometimes it is a provider. Sometimes it's somebody who just has a particular instance or interest in, you know, today we're talking about blood pressure, so maybe somebody has a particular interest in blood pressure and is really kind of a cheerleader for the work and a champion and somebody that people in the clinic take their lead from. You know, if that person says, hey, we're excited about this and this is what we're going to do, and everybody seems to rally around that person, then that might be your champion. But we've often found in this work that it is critical to identify that person from the start to really get the momentum going and to keep it going.
Yes, I agree. And if the physicians are not the leadership at your organization and leadership has not bought in, that champion can also help to get that organizational change from the top, not just to spread it laterally and throughout the other staff.
Thank you. I think that's a fantastic point about creating buy-in, and I was thinking even maybe a patient might be your champion, depending on how engaged your patients are in some of your care. If you have a patient or family advisory council or committee, might be one way to do it, or if you practice peer coaching also. There are a couple other questions I want to make sure we get to. One was about the what type of validated blood pressure monitors are being used in the office setting. I know we spent just a very short amount of time talking through the blood pressure categories and some of the monitors, but any thoughts on that question?
Yeah, this is Rebecca. There are some different websites that will show you some validated machines, or you can check the machine that you have to see if it's validated. But with our local Utah Million Hearts Coalition, we developed a document about purchasing a validated machine and purchasing actually a validated automated machine, because that is best practice. And that document can be found on the website, the www.healthinsight.org/blood pressure. I saw that Marissa put that in the chat box for you, so you can go and grab it there if you need it for reference. But if you go to that coalition website, there's a category, a link on the right-hand side, the accuracy of blood pressure readings. In that tab, you will find some different documents, and one of them is about purchasing a device. In there we have a few suggestions for validated devices that you can look at as a starting point.
Great, thank you, Rebecca, for guiding folks to that resource. One last question we had was about staff time and how much staff time it takes to contact patients who aren't reporting weekly blood pressure findings. I think this is for Jenny and Amber. And also, how much time does it take you to teach patients initially on how to take their own blood pressure at home.
I'm going to let Amber go ahead and answer that question for you.
Hey, thank you, everyone. It might be a little noisy in the background here, so I apologize if it is. But as far as the initial visit with a patient to give them the training on their blood pressure monitor and how to place the cuff and all of these things and all of our discussion, it takes about 10 to 15 minutes. It depends on how many questions the patient has, for example. And as far as actually tracking down the patients who haven't been complying, that is something that so far I simply have not had time to do. I've been so busy with the inputting the data from the patients who actually are complying with the program that we haven't yet gotten to that part of it. Jenny, did you want to add anything?
So if you have it in your budget somehow.
Yes, thanks, Amber. We have done studies rolling it out. So when we roll this program out to our other sites, we don't have the staffing to be able to have a community health worker or other resource at every patient as we expand to have weekly readings done. So in the rollout, we're working actually in partnership with the American Heart Association to use Heart 360 as the tool that would actually be recording the daily readings for our patients. And in that, so it's taken what Amber experiences and it's kind of pared it down to about a 10-minute visit. It'll take about 10 minutes to have the patient sign up for the Heart 360 account and then also have the training on how to do a proper blood pressure reading at home.
Thank you, Jenny and Amber. Also a great resource at American Heart Association. There are lots of fantastic resources and tools, protocols, guidelines out there, and we will link to some of those on the HealthInsight website when we post the recording to the subsite and the slides. And I want to encourage people, there's still time to submit your PDSA or action plan if you'd like. But with that, I will share that our next webinar is actually, our next LAN event is actually a call, and it will be a cardiac care highlights huddle for folks to share practices that are working in their setting and also things that they are continuing to work on and that they'd like to have some help with. That will be Thursday, July 14th. As I mentioned before, please do complete the post-webinar survey. We are always trying to improve these learning events to make sure they're valuable for you, and that we're also addressing topics that are going to be useful in the future. There are also a few resources here that we mentioned, and we will link to additional resources on the website. But other than that, I want to thank everyone for being on the call today and going through these topics. And I want to give a tremendous thank you and appreciation to all of our speakers today. I really appreciate your preparation and your willingness to share and be thoughtful about this. So thank you, Rebecca. Thank you, Susan. Thank you, Jenny. And thank you, Amber. And thank you, everyone else. Have a great rest of your afternoon.
Thank you.
Thank you.